Briefly, I just want to thank the folks who put together this amazing symposium. I am a pediatric neurointensivist, and I'm going to talk about respiratory issues to consider with children with acute flaccid myelitis in the intensive care unit in the acute phase. Unfortunately, I do not have anything to disclose, but the objectives I'm going to go over today, we're going to go over the supportive measures that hopefully help prevent intubation if possible. We're going to talk a little bit about what respiratory failure looks like in these children, and then go over some suggested criteria for intubation, extubation, consideration for tracheostomy, and then we're going to end on some suggestions for procedural sedation, prolonged sedation if your patient does need to be intubated for an extended period of time, and then touch on some pain management as well with these patients. Oh goodness, sorry, my screen. Okay, there we go. With that said, we do know that children with acute flaccid myelitis are, they're all at risk for acute respiratory failure. And like Dr. Carpenter said, it's hard to say exactly which ones, but a good percentage of them are, and more so in the acute phase rather than the extended phase. But as Dr. Carpenter reminded us, we do know that high cervical spinal cord injury, specifically the C3 to C5 region, as well as brainstem involvement, can really affect the phrenic nerve and the direct cardiac innervation of the heart. So those injuries, really put children at risk for respiratory failure as well as significant autonomic instability. We also know that acute flaccid myelitis associated with enterovirus D68 has been reported to have more severe outcomes than other etiologies, leaving the children at higher risk for permanent neurological injury, in addition to prolonged respiratory failure. And also we know that children who present with severe weakness at the peak of their illness tend to have less good recoveries and prolonged respiratory failure compared to other children. So Dr. Leslie Benson, who's giving the talk after me, actually published a paper in January of this year reporting on 167 children that she reached out to a closed media face group of parents, sending out several surveys. And based on the survey responses, she found that on average, the initial hospitalization of children with AFM lasted about 49 days, followed by 42 days in inpatient rehabilitation. And that about 80% of the patients in her survey suffered respiratory difficulties in the acute phase of their illness, whereas only about 22% chronically suffered from respiratory difficulties. She also reported that about 25% of these children required tracheostomy, and that the average length of or the need for a tracheostomy was just over 15 months. But to put it into perspective, it seemed like that a lot of the children that required tracheostomy and mechanical ventilation within about a 6-month period were actually able to transition off of mechanical ventilation, which is really some very exciting news. To put into perspective, when she surveyed her group in 2014, there were 36 children at that time who were ventilator dependent. Looking at that same group in 2018, only 3 of those 36 children remained ventilator dependent. So with AFM, there's a lot more questions than answers at this point. A lot of the knowledge that we have is anecdotal, based on small case series, moderate size case series. We're still trying to figure out the exact pathophysiology and, really the best treatment options here. So the one thing that is clear is that we definitely need coordinated research efforts with large number of cases across many different institutions to really help bridge these knowledge gaps. So Carlos Pardo, along with some other folks, several years ago, developed the Acute Flaccid Myelitis Working Group, bringing a massive multidisciplinary group of providers together to help tackle these issues. And out of that larger group came a small subcommittee of pediatric neurointensivists who all got together over a series of phone calls over extended periods of time. We had contributions from 15 different institutions to really develop some recommendations for acute management of these children in the pediatric intensive care unit, We had pediatric intensivists, pediatric neurointensivists, neurologists, and physical medicine and rehabilitation providers really come together to create these recommendations, much of which I'm going to go over for the rest of my talk. So what does respiratory failure look like with AFM? We know it's really primarily a hypoventilation problem secondary to weakness or secondary to the not having the ability to protect your airway. So it's really not a hypoxic respiratory failure, which is what we primarily see in the pediatric intensive care unit. So as a pediatric neurointensivist, when AFM is suspected, I would say the first and most important step is to make sure that the patient's airway is protected and to keep it protected the entire time. So with that said, have a low threshold if you're really worried about respiratory compromise to send these children to the pediatric intensive care unit for close neurological monitoring and to watch for respiratory failure, especially with those patients that have the high cervical spinal cord lesions and the brainstem involvement. So what does respiratory failure look like? As Dr. Carpenter reminded us, these children, they don't get tachypnic, they don't have increased work of breathing, they don't have the signs that we normally see when children are failing from a respiratory standpoint. Instead, they become weak. They have poor head control. They start drooling because they've lost the ability to manage their own secretions. Their swallow is getting profoundly weak. They often develop a soft voice, followed by losing the ability to speak at all, and just followed by profound weakness. So as Dr. Carpenter said, we monitor these children very closely with end-tidal carbon dioxide monitors, the side stream monitoring, watching for any elevations in carbon dioxide, and we also monitor them closely with pulse oximetry. But again, if you're waiting for a patient to become hypoxic, you're probably waiting too long, given that that's a later sign. And then, like Dr. Carpenter said, we follow negative inspiratory forces, forced vital capacities every 4 hours in our older children. And in our younger children who are not able to cooperate, we have them do their ABCs. Do something in a single breath so that we can compare that every 4 hours to see if they're getting stronger or weaker. And so there's a lot of supportive measures to help minimize the risk of respiratory failure in these kiddos. So early mobilization, lots of physical therapy, occupational therapy as soon as they're able to tolerate it, getting these kids as active as possible to prevent the deconditioning that we know sitting in an ICU bed alone, even outside of AFM, can affect. An aggressive pulmonary toilet, frequent suctioning, lots of chest physiotherapy, cough assist, inhaled nebulized medications, inhaled mucolytics, anything you can do to keep the airways open and to help keep them clear. Aggressive screening for infections, so identifying bacterial pneumonias and treating them, and identifying influenza and treating that. So identifying anything else that could be making these children weak or struggle from a respiratory standpoint is super important. We also want to minimize the sedatives and the sleep aids that we're giving. We don't want these children to sleep very deeply. We don't want them to get weaker while they're asleep. And we want to avoid any medications that could cause weakness in and of themselves, like magnesium, paralytics, steroids, and opioids specifically. And then also to help protect the airway, if there's any question at all, we really suggest getting formal swallow evaluations before allowing children to feed by mouth if there's any question. Chronic or silent aspiration in these early stages can really set up for a bad chemical pneumonitis in the lungs later on. And then when in doubt, over-treating these children a little bit with negative pressure, with non-invasive positive pressure, ventilation should be highly considered, especially when they're sleeping at night, potentially putting them on a low level of BiPAP just to assure that they are breathing throughout the night and that we're keeping the lungs open and that they're not collapsing down. So suggested thresholds for intubation, very similar to other neuromuscular children, like children suffering from Guillain-Barré, botulism, spinal muscular atrophy. So the objective measures that we often use is a vital capacity less than 20, a negative inspiratory force less than 30, or any signs of carbon dioxide retention, specifically a threshold over 50, and then again hypoxia. But the reality is Personally, I've unfortunately had to intubate many children with acute flaccid myelitis, and talking to many other neurointensivists, if you're really waiting for hypercarbia, hypoxia, and these things that I've objectively listed out, you're probably waiting a little bit too long. Many neurointensivists are actually using the threshold of, do they have a cough and a gag? Are they able to speak? And are they able to swallow their own secretions? And often when the cough and the gag become weak and the ability to speak is gone, that's the trigger that a lot of neurointensivists are using to place the breathing tube, not wanting to put these children at risk for potentially suffering from a hypoxic ischemic insult if we wait too late. So once it's been decided that a breathing tube needs to be placed, we also encourage people to really consider in the younger patients potentially a nasal intubation, given that often when patients are intubated nasally, they require less sedation. And then once the breathing tube is placed and mechanical ventilation is initiated, transitioning to a mandatory minute ventilation mode as soon as possible so that these kids are able to exercise and work the respiratory muscles that they have, again, to prevent any deconditioning that intubation might be contributing to. So criteria for extubation, we really suggest a prolonged extubation readiness test. Now, typically, extubation readiness tests we perform for 30 minutes to 2 hours. In these situations, we'd actually encourage a very prolonged course, anywhere from about 24 to 72 hours, just to make sure that these kids aren't going to tire out during that period. And so essentially what you're doing is putting your ventilator into a pressure support and PEEP mode only, and you're going to calculate the pressures that you need, basically just to overcome the circumference, the diameter of your breathing tube, so that the patient is essentially breathing on their own without the breathing tube making it more difficult. Now, as you're in this pressure support and PEEP mode, you're looking for tidal volumes, ideally 5 cc's per kg or greater. You want them to maintain normal saturations with a minimal amount of oxygen. And then you're going to watch them and make sure they don't become too tachypnic, they don't become tachycardic, sweaty, that they really aren't suffering. So you want to make sure that they are in a state that will be maintained safely if that breathing tube is going to come out. And then anecdotally at our institution, every single AFM child that we have extubated straight to BiPAP. So we strongly, at our institution, that's what we do, and many other neurointensivists across the country are strongly encouraging that as well. Again, being very aggressive with a non-invasive support while these children are getting stronger to help keep the lungs good and open. So considerations for tracheostomy, there's kind of two big things to consider here. And with talking with our international group, if your institution has a inpatient rehabilitation center that they can transition these children to very quickly, and respiratory failure is the only thing that's holding that transition up, then perhaps a very early tracheostomy in order to facilitate rapid transition to inpatient rehab should be heavily considered. Now, if you don't have an inpatient rehab center that you can quickly transition to these children to, then a traditional trial of extubation should definitely be offered. But if a child fails extubation twice and doesn't have new infections associated around those extubation trials, and at that point you should heavily consider tracheostomy in these patients. Some institutions are offering early diaphragmatic pacers as a possible way to avoid tracheostomy, but not many institutions, unfortunately, are doing that. But at the end of the day, if you have a patient with significant high cervical spinal cord injury or brainstem involvement or just profound weakness, not a strong cough, not a strong gag, inability to control their own secretions, those patients really should be highly considered for a tracheostomy. Okay, so when we're talking about sedation, we really encourage that you look at your institution's sedational protocols here and maybe not follow them like you would other patients. AFM children really need their own personalized sedation regimen. So we really want to not expose them to medications that are going to precipitate or worsen respiratory suppression. So we strongly encourage procedural sedation with dexmedetomidine infusions, ketamine infusions, propofol, things along those lines. Try to avoid the opioids and the benzos, but if you have to give them, give the agents with shorter half-lives, so fentanyl over Dilaudid, Midaz over Valium. And then looking at the procedures that you're having to sedate the child to, really ask yourself, is there any way I can shorten this procedure to avoid the sedative agents that I'm going to give? If you're sedating for an MRI, really don't do an elective intubation if there's any way, because it's going to be very difficult to extubate this patient. Is there any way to shorten that MRI to get the most high yield sequences first? And then maybe not worry about the less high yield sequences at this time, but maybe do that in the future when they're a little stronger. And then look at your environmental modifications. Can you integrate child life? Can you integrate the parents, or other things that'll keep the children calm in a manner that we don't have to give drugs to them to do so. So aside from procedural sedation, we're talking about these children that we're sedating just simply because they're intubated. A lot of these children, because of their spinal cord involvement, they're profoundly weak. They have blunted sensation. So the breathing tube doesn't bother them as much as a lot of other patients in the PICU. So a lot of these children actually do not need continuous infusions to keep them sedated. A lot of times you can just give intermittent doses of medications. But if you think the patient needs a continuous infusion of sedatives, providing dexmedetomidine is highly recommended unless your patient has significant autonomic instability. But again, trying to avoid those narcotics and really looking at alternative medications like clonidine and gabapentin. So now transitioning to pain in AFM patients. So again, hard to identify because they're so profoundly weak. But, really looking at the first 14 days after the onset of paralysis, a lot of the pain is due to muscle spasm. So I know I've said to avoid the benzos, but Valium at a very low optimal dose during those first 2 weeks can actually provide a good amount of pain relief. And again, at a nice low dose. Now, once you transition into the 2 weeks after the onset of the paralysis, it's really a lot of nerve pain that these patients are suffering from. So highly relying on medications like gabapentin. And then also important to note that if you have a patient who's so weak that their eyes are unable to close, really putting them on scheduled Lacrolube and things along those lines to help prevent corneal abrasions to them. So in conclusion, respiratory failure from an AFM is most often hypoventilation, not hypoxia, due to weakness and the inability to protect the airway. When AFM is suspected, the first and most important step, in my opinion, is to make sure that the patient's airway is protected. Have a low threshold to send the patients to the pediatric intensive care unit, especially if they have high cervical spinal cord injuries or cervical spine involvement or brainstem involvement. And then have a low threshold to over-support these children with non-invasive BiPAP, CPAP, high-flow nasal cannula, especially when they're sleeping at night. Minimize sedatives and really try to never perform an elective intubation unless absolutely unavoidable in these patient population. And then do whatever you can to prioritize the rapid transition to inpatient rehabilitation. And these are just amazing folks that I've worked with over the last 2 years on this. And now we're going to hear from Dr. Leslie Benson, the Assistant Director of Pediatric Neuroimmunology and Assistant Director of Pediatric MS and Related Disorders at Boston Children's Hospital. She's going to talk to us about what we know about treatment in AFM.